Okay, I have 8 o'clock, so let's get started. Our DMEC conference today is being given by Dr. Stuart Leicht. We all know him. He's Professor of Medicine, Chief of Dermatology at ETSU. He is going to be talking today about dermatitis and therapy as part of the lecture series in dermatology, both for your boards and for our DMEC curriculum.
We on? Sound like it's on? Indeed we are. Today we're going to discuss a common topic of something that you see all the time. I like doing these in a very pragmatic fashion. Some of this may be on your boards anyway, but all of you have the opportunity to see patients with these problems, and I think you should be familiar with the diagnosis and therapy, or at least familiar with what we do with them. I have no conflicts of interest, though I wish I did. By definition, dermatitis is an immunologically mediated inflammatory disease. It's characterized by aspects or attributes of erythema scaling, edema, itching, and loss of protective function. So it's a process where you get a non-specific inflammation of the skin, as we're going to go through. From the standpoint of discussions and what you read in the book, dermatitis is essentially a synonymous term with eczema, which is an older term. The pathology is spongiotic, meaning that there's intracellular edema, and it's a lymphocytic inflammation, so it's an immunologic process. Most skin diseases, by default, are really felt to be immunologic illnesses. Although we don't know what the etiologies there are for some of them. I suspect some may turn out to be infections and whatever, rather than autoimmune sorts of things. And there are distinctive clinical patterns that I'm going to emphasize to you. Again, these are things that you're going to see all the time in your practices. All the processes show a similar, rather non-specific inflammation. We call it a slurpy. It's a superficial perivascular, meaning that the lymphocytes are around the vessels, lymphocytic inflammation. Neutrophils are really absent from this. And as I'm going to emphasize a little bit later, there are fundamentally different attributes about processes that recruit neutrophils into the area than lymphocytes. They're really entirely different disorders. Under the microscope, although these things look very distinctive to the unaided eye, under the microscope, despite great variations, they all pretty much look the same. There's a variable amount of edema, scaling, and almost always pruritus. And on different individuals, these look somewhat differently. On an African American versus a Caucasian versus a child, they may have somewhat different appearances, and that's part of the challenge of dermatology, that similar diseases are going to look different on different individuals and different groups. Because of the nature of the inflammatory infiltrate, the response to corticosteroids and other immunosuppressive agents that we'll get into, it's presumed to be a type 4 immunologic reaction. So when you're designing therapy, you need to keep this in mind. It's not an allergy in the sense that an allergist would treat these things. There are multiple ways to categorize this. One of the simplest is acute, chronic, and subacute. Acute meaning vesiculation, blistering, a great deal of edema, sudden onset. Chronic, where you get processes with marked scaling, minimal erythema, a lot of hyperkeratosis, itching, and it's long-standing. And subacute is a combination above. These are the diseases that we're going to be talking about now. You're familiar with many of these, I think, by default. One of the circumstances that's peculiar about medical education is that I think a lot of the internists, the attendings that train you have had really very minimal exposure themselves to dermatology. So although you may learn about cardiology from your general internist, you may learn some endocrinology and other specialties, for the most part you're really not going to get any good information regarding dermatology, because I think the practical or pragmatic information that they have is kind of limited, so things get ignored. But I'm sure you've seen and are familiar with a lot of these things. Contact dermatitis, seborrheic dermatitis, stasis, dishydrosis, nummular, exfoliative. We're going to discuss all of these because they have distinctive appearances that you wind up seeing. Contact dermatitis, there are two major types that we're going to talk about. There's an irritant and allergic. An irritant contact dermatitis is an injury that's brought about by a material that can injure anyone's skin. We're talking about solvent properties, pH, salt attributes of the material, so that given a sufficient concentration and a prolonged enough exposure, it would damage anyone's skin. You get into Clorox, you get into acids or bases, you have your hands immersed in soap, you're a surgeon, you scrub with soap or detergent all day long, you're going to eventually injure your skin. An allergic contact dermatitis, as you recall, is a type 4 cell-mediated hypersensitivity where you have a sensitization period. You develop, the antigens are presented via antigen-presenting cells to lymphocytes where they're sensitized, and then thereafter it requires minute amount of material to create a reaction. So these are in previously sensitized individuals. So anyone can develop an irritant contact dermatitis. Allergic contact dermatitis is much more specific to the patient's genetic makeup. As you'll see or we'll discuss with poison ivy, probably only 60 or 70% of the people can develop that. Doesn't matter how much exposure. There are 30 or 40% of people who are never going to get that reaction. And animals don't get it either. Your dog running through poison ivy isn't going to get it because genetically they're not predisposed to react to that material. Allergic contact dermatitis, there's some things that you need to do to really make the diagnosis. I get patients all the time that are told they have contact dermatitis, and they're not just from internists. I got a patient just the other day that came in with multiple bumps all over their legs where clearly there was no logic to it, and they were told by a local dermatologist that they had contact dermatitis, which is patently absurd. You suspect the clinical diagnosis by the pattern, the patient's discussion of activity and the time course. You can document it by patch testing. Now, it's important for your boards. We're not talking about RAS testing. We have no conflict with the allergists in this. We really deal with different types of allergy. The allergist, for the most part, is dealing with a type 1 hypersensitivity, and we're dealing with a type 4. And there's really not much overlap. We don't deal with that at all, and they, for the most part, don't test for what we're dealing with, and we get a lot of referrals and send referrals to them depending on what the mechanism is. So you can do RAS, prick, or scratch testing for type 1, but patch testing, utilizing the material actually on the skin, is for type 4. You can confirm the reaction by a provocative or use test, but ultimately the only treatment is going to be education and avoidance. You can't desensitize people to a type 4 mediated reaction. Were that true, you can do transplants, organ transplants on people and not have to give them immunosuppression. The immune system really, as far as we know, it doesn't negotiate at all. It has the Vietnam complex. To save the village, you must destroy the village. It is not tolerant at all. It continues on. The only way to have a foreign material in your body is to suppress the reaction that's occurring to it. To be expert in this field, and it's almost a subspecialty really with dermatology, clinician needs to be knowledgeable as to what ingredients and antigenicity are in many products. However, you need to be familiar, I think, with certain common things. Poison ivy, allergies to nickel, chromates and cement. There are a few things that you're going to see in everyday practice where patients are going to come to you where I think a knowledge of the common things are going to be important. As I said, you cannot be desensitized to your allergic contact dermatitis. All you can do is be educated and avoid it. If you know that you have a nickel allergy, you're only going to wear gold jewelry, or you're going to avoid certain things. If you're very sensitive, there are even certain foods that contain higher quantities of nickel that you may react to. And treatment, again, is primarily identification of the offending material and avoidance. Contact dermatitis, as I said, is virtually a subspecialty due to the myriad materials that are involved in the environment. I sometimes refer patients for more specialized patch testing. Another difficulty with that is that the standard patch test only contains a certain amount of materials. The FDA has approved these materials as safe and effective. In Europe, they have hundreds of different patch test components, and a lot of the people that specialize in this actually will bring in or have access to these things that are not approved by the FDA and do testing by it. But for the regular dermatologist, it's not cost effective and it's rather difficult to get hold of these things. It's a cell-mediated, not type 1, so you don't see hives or anaphylaxis. You're not going to develop that. Type 4 reactions are treated, as I said, by dermatologists, and it's screened by patch testing. Now, this is an example. Is that in focus for you guys? This was a genius that I saw at the VA who had a rash. He thought he had Tinea pedis, and he decided to treat it with Clorox. So he kept putting on the Clorox until he eroded his skin, developed necrosis in other areas. This is a irritant contact dermatitis. You need to stop the material and allow it to heal up. This is poison ivy. When you're dealing with poison ivy or similar sorts of materials, what you look for, and with an allergic contact dermatitis in general, you look for linearity. Okay? That's an abnormal, it's an abnormal response to the skin. You don't get geometric lesions forming on the skin. You're incapable of doing it. You don't form squares, rectangles, perfect circles, right angles, and linear lesions for the most part. Most lesions spontaneously are ellipsoidal. So when you see something like this, it infers that something from the environment has contacted the patient. And the reason you get the linearity is that people will brush against the vines or the leaves and wind up getting the reaction to this. And then you often get a very florid blistering reaction. There's another misconception about this that I should bring up. That's the patient feels that he or she is spreading the material by touching the blisters and washing whatever. That's really not true. The material that is in urushiol is a haptene. It's an electrophilic material that bonds irreversibly with skin proteins within 20 minutes. If you get into poison ivy and you wash vigorously, within 20 minutes you can obviate the entire outbreak. But once it's bound, you're doomed. It's a haptene. If you react, you're going to get if you're sensitized to it, where you're going to react, you're going to get the reaction. And there's a dose-response effect. And that's what gives patients the belief that they're spreading this. The areas that get the highest concentrations are going to break out first, and then they're going to continue to develop further breakouts over a period of time because the lesser areas are going to take longer to break out. This is another example of urushiol or poison ivy contact dermatitis, so it's allergic contact. And one of the things that you can see with this is called a black lacquer dermatitis. In high concentrations, the urushiol will oxidize and give a black area, which is a clue. You can see the vesicles coming off from that. Poison ivy sometimes can be somewhat of a medical emergency depending on where you get it. If you get a lot of swelling around the penis, the genitals, where it can interfere with function, get it around the lips or the eyes, you ingest it and have some problems there. You can even get an allergic pneumonitis. Firefighters out west where they're working around forest fires where there's poison oak, which exists in the higher elevations, will sometimes inhale a great deal of this and actually wind up with a pneumonitis and require steroids and hospitalization for that. So at times it can be a medical emergency. This is what we call dermatitis medicamentosa, where a patient will put on a topical preparation that's prescribed or recommended them and breaks out. And this will be like triple antibiotic ointment, bacitracin. One stops and thinks about it. Most of the antibiotics that we use in dermatology topically are pretty useless materials. They're things that are not useful systemically because the risk of putting something on your skin is sensitizing the patients. And the manufacturers are well aware that the last thing you want to do is have someone use an aminoglycoside or a cephalosporin on your skin, wind up with an allergy, not being able to use that material to treat a serious infection. So for the most part, the drugs that we're restricted to are pretty useless. And one of the problems is that they will sensitize individuals. This is another reaction, allergic contact dermatitis to a topical antibiotic. And one of the things we sometimes see is that the patients will get a reaction, they'll treat something, it'll get worse. The worse it gets, the more they put the material on. The more they put the material on, the worse it gets, and they'll track it around. You'll wind up with some horrific eruption because they just don't put together two and two. This is, I forgot putting the slide either. I think it's a nickel dermatitis where it's under a ring. A lot of the jewelry, cheaper jewelry, is amalgamated with nickel, which can leach out and is a potent sensitizer. with that. Pure gold obviously isn't going to do that. There can be rare reactions to that, but the nickel is quite common. I will say that the nickel in coinage, in coins, won't do that for the most part. It's a different salt. It doesn't leach out and doesn't cause the same reaction unless someone is extremely sensitized to it. So you don't really get a history that they're handling money. And these days, I'm not even sure they put nickel in nickel because it costs more than 5 cents to put it in there. Another thing to think about with this is going to be soap getting under the jewelry and causing an irritant contact dermatitis. Let's move on to seborrheic dermatitis. Seborrheic dermatitis is a red flaky eruption. It affects what's called the T area of the face, the scalp, the beard, frequently in the ears, around the ears, the external auditory meatus. You can get it around the eyelids, which have the greatest concentration of sebaceous glands. You can get flaking within the eyelashes itself. And usually only in males we'll see it on the chest and the upper back where it may initially present that way. Occasionally it can even occur in the axilla groin. Your patients, and you probably know it as dandruff. I regard dandruff as seborrheic dermatitis and seborrheic dermatitis as dandruff. Some people separate them out. If there's no inflammation, they call it dandruff. If there is, they call it seborrheic dermatitis. It's probably related to Pityrosporum species, and traditionally we talk about Malassezia furfur. But as we've done or we've done PCR studies, we've learned that that really has less to do with all of these things. Most recent studies show that it's that should really be Malassezia restricta or Malassezia globosa, which were separate subspecies. Even Tinea versicolor that you learned was Malassezia furfur, in fact, isn't in the majority of studies. It's these other subspecies. However, the response to antifungals is variable, and you'll read articles that say, this is the cause of it, there's a hypersensitivity reaction. But if you use topical antifungals, it doesn't always work. I don't use a lot of ketoconazole. When it works well, and you can avoid the steroid effect, but it's unpredictable as to whether it's going to really have an effect or not. A number of the manufacturers have tried to put these materials in shampoos. You certainly have ketoconazole shampoo that you're probably familiar with. They've put others in shampoos, but they really don't seem to work very well. So there's something else going on, and I suspect that there's a hypersensitivity reaction to small amounts of the yeast that keep this thing going, and you're incapable of eradicating it completely with these materials. So it isn't a one-to-one relationship, and I think the best we can say is the etiology is debatable. As I said, seborrheic dermatitis is dandruff, and dandruff is seborrheic dermatitis. Patient typically complains of persistent or seasonal dry skin. You don't get dry skin on the face like that. If the patient has it, so-called dry skin, almost invariably it's going to be seborrheic dermatitis. It doesn't relate to the fact that they're not drinking enough water, not eating enough fats, or using too much soap. One of the things that isn't emphasized in literature is that rosacea is almost always complicated by seborrheic dermatitis. Rosacea is very common in itself, and if you look at your patients with rosacea, you can almost always, for some reason, find an attribute of seborrheic dermatitis. It's the most common cause of otitis externa when you have young kids and other individuals that have otitis with a lot of itching. Almost invariably, it's seborrheic dermatitis. It can cause blepharitis, and on the scalp, it's frequently misdiagnosed by clinicians as psoriasis. So these are the areas that you can see involvement with: the chest, the back, the T area of the face, the scalp, ears, occasionally the groin, the axilla, and we'll show you some examples. This is a patient I had at the VA who has these red scaly patches. Again, I'm at an angle, but is it in focus for you guys? I guess I could look in here, because these are incredible pictures. So the patchy erythema over there, you can see it in the beard area, typically around the nasophageal sulcus, the malolabial line. You get it behind the ear, extending into the scalp. You get it in the scalp itself, where there can be dense or diffuse fine flaking. And you can get blepharitis with this. I don't think it's really established whether it's the physical effect of flakes going in the eye or you actually get inflammation around here, but you can see the purulence, the crusting, and when it's very severe, it can cause some ocular problems. This is an example on the chest where you get what's called a petaloid, these oval areas of erythema. Sometimes there's a more papular attribute about it that Looks almost like a folliculitis that it can blend into. It's usually not symptomatic, but you'll see males with this. For some reason, it doesn't affect females. It's really not commented on, but it's rare in females. And you can get it on the upper back where there's fine flaking also. The axilla can look like candida or a contact dermatitis, say, to deodorants and things, so it can be confused with that. When you're presented with a patient like this, you have to keep your eyes open and look for the forest here. And you look on his face, and there's all sorts of red, patchy, delimited scaling. So this is seborrheic dermatitis by default. Oken's razor is functional here. You don't give patients multiple diagnoses when one will serve them all. All right, move on to stasis dermatitis, and this is an important topic because it has certain features that I think confuse a lot of clinicians. This is an episodic inflammatory disorder that complicates chronic venous insufficiency. Venous insufficiency is due to superficial venous hypertension. About 80% of the venous return from your legs goes through the deep system, which is a high-pressure system with valves that shunts the blood up back to your heart. Okay, these would be the saphenous vein, the popliteal veins, and such on there. About 10% of the flow goes through the skin in the superficial venous system, which generally is not a valve system for the most part. Well, there are valves, but not as vigorous as that. The blood shunts from the low-pressure system into the high-pressure system. When you get venous disease, what happens is you get either constitutionally due to wear and tear, or you have a DVT that blows out the valvular system in your deep venous system. And what happens is that you start transmitting that pressure back to the superficial venous system, which is really incapable of dealing with it. As a result, you wind up with varicosities, you wind up with spider veins and thread veins. The vessels become leaky because of alteration of Starling forces. You get blood that comes out as vessels burst, capillaries burst. You get hemosiderin deposition, edema, and periodically it can be characterized by this inflammatory process. So you can get acute itching, erythema, edema superimposed on the more chronic process. We don't really know what causes this. This has a tendency to spread. So if you piss it off or you don't treat it right, it can start in your legs and it can generalize. It can even result in a total body rash. And we don't fully understand what's going on. It's been called autoeczematization or conditioned hyperirritability, but we see it all the time. So it has a proclivity to spread if you don't treat it. And therefore, the patients may present with a generalized eruption, and you need to ask a history as to where it began. If it was on the legs, you know it's a stasis dermatitis, and you can direct attention to that more appropriately. In the differential, you have to distinguish this from cellulitis and DVT, and this is where a lot of the problems come about. Stasis dermatitis itches, sometimes terribly. Cellulitis burns and hurts, sometimes terribly, and is intensely red, where cellulitis is a duller sort of red, but you know, we're talking about quality or differences in quality here. Cellulitis, to make things worse, can complicate stasis dermatitis, so there may be a slight component of itch, but usually the stasis dermatitis is markedly itchy and minimally painful. So stasis dermatitis is frequently, though not always bilateral. Cellulitis is rarely bilateral. I see this over and over again, and it drives me crazy that I get patients that are admitted to the hospital with bilateral cellulitis. Dr. Moorman may disagree with me. I don't know. But think about it. Infection is a very rare event in your body. And despite the immunologist thinking that the adaptive immune system is all-encompassing and it's your cellular-mediated system and your humoral-mediated system that protect you, that's not true. It's your innate immune system that protects you. That's what keeps you from dying for the most part. By the time these things kick in, you'd be 80% bacterial antigen. So what really keeps you alive most of the time is your innate immune system, which 99.999% of the time beats off whatever is going on. You're not even aware you've been infected. So think about it. What's the likelihood that you're going to develop infection in two separate sites at the same time? I mean, it's vanishingly rare. So that most of the time when you get someone that presents with redness and swelling bilaterally, it's going to be stasis dermatitis. And if you bother to take a history, there may be a little bit of discomfort, but it itches like crap. But usually what happens is we find the patients get admitted by their primary care physician to the hospital. They're put on, Godzillacillin or Cefladudu or some other exotic material. They get a PICC line. I had a patient had a PICC line put in for this. And they put them at bed rest with their legs elevated, which was one of the treatments for stasis dermatitis, and they get better. And everyone thinks that, they've done well. They've racked up a $20,000 fee for the hospital course. So I just want you to be aware, it's extremely unlikely to get a bilateral cellulitis. And when you get a suddenly inflamed foot where it's itchy and they've had baseline stasis, that's really what you need to think about. They've actually done studies looking what's the incidence of DVT with these things, and it's really it's a minority of patients. I still think that if you have suspicions, you need to rule that out. But you certainly don't want to you don't want to admit the patient, sight unseen into the hospital for this. So this is venous stasis. You get hemosiderin, you get edema. The edema is frequently painful when you press in, or it's tender. And they may or may not have obvious varicosities, thread veins, spider veins, and such. This is stasis dermatitis, and you can see the erythema, which is not really bright red, extending above this. There's itching, more scaling. There can be vesiculation, oozing, and weeping. This should be, let me see on my picture here. This is an example of cellulitis unilaterally. And you get a painful swelling. It doesn't show up, I suppose, as well. But the rest of this is bilateral stasis dermatitis. So you certainly can get a cellulitis on top of that. And this would be a cellulitis also over here, where this extends a lot more. There's a dusky, more of a bright red erythema. It's quite painful. The patient's not going to complain to you of itching. It hurts. It's blown up quite suddenly, and that needs to be treated. Though I will say, again, Dr. Moorman can argue with me or not, the majority of these things without a purulent focus are still going to be strep. You do not need to put a PICC line in them and treat them with vancomycin. I treat most of these patients with ampicillin or Augmentin, and I've even treated them with penicillin as an outpatient. I think, unless they're immunosuppressed or they're, in terrible condition, they have all sorts of comorbid situations, you can carefully follow them as long as they can take the medication orally, and there's no problem with that. You can carefully follow them as outpatient, and they'll do quite well. These are, for the most part, they're very sensitive organisms, and you don't need expensive antibiotics to treat it. Would you agree with that? He absolutely agrees with that. You heard him. All right. More stasis dermatitis, marked swelling, edema, itching, acute onset. Dyshydrotic dermatitis. This goes by the old name of Pomflex. 25% of people have this. And we'll describe that, and I'll ask you how many people have had that. I've had it before as little blisters. It's called boiling in the old, or Pomflex in the old literature. It's a misnomer. It really has nothing to do with the sweat glands. We don't know what the etiology is. It's extraordinarily common, at least in minor components. It presents as relapsing crops and waves of tiny blisters that are called dyshydrosiform. They almost look like little frog eggs, characterized on the sides of the fingers, the palms, and the soles. So it's usually on the distal layers, intensely itchy. Can also be sore. They dry up, crack, lead to scaling, macules, and plaques, and it repeatedly recurs. Now, one thing I want to emphasize to you guys is that these are blisters. They're not pustules. If they're pustules, you have an entirely different process. Blisters mean that you have a lymphocytic infiltrate. There's a sparse infiltrate of lymphocytes. It's a cell-mediated process. If you have pustules and neutrophils, you probably have something pyogenic or akin to psoriasis going on. The differential is entirely different. You shouldn't, at least by my way of thinking, you should never see pustules with this hydrosis. And if you have pustules, again, it throws it into a different category. If it's important to distinguish, you do a biopsy, as I've sometimes done. So this is dyshydrotic dermatitis. You get these minute, shiny blisters, usually on the sides of the fingers. Anyone have this? I've had it. I mean, it really, I don't believe you guys. A quarter of the population has this at some time or another. I'm not talking about severe, but you look down, you've got little bumps there. again, in the thicker skin of the palms and the soles, you may just have these little clear areas, these little gray areas where these blisters are. And typically it itches very bad, but not always. Symptoms are very variable. Now these are pustules. This is different. You get these succulent yellow or yellowish green areas, and this is entirely different. This happens to be pustular psoriasis. I see this even coming in from other dermatologists where they treat people for dyshydrosis, and it's actually pustular psoriasis, so I can't fault you guys. But if you look at these things carefully and think about it, you'll probably be able to make a diagnosis just as well as a dermatologist. Sometimes they're more severe. You can see myriad small, shiny vesicles there. Multiple lesions here. When they're older, they can get desiccated and brown, but still these are blisters. And this is the old pamphylix, the boiling. These are very dramatic patients that present with acute onset of blisters, huge blisters that become confluent. They're painful more than itchy. They prevent ambulation. Patient is disabled with this. And I've found that if you give them an injection of Kenlog, there's just a remarkable improvement. Within a few days, it's virtually gone. And when it's this severe, it tends not to recur. It's another example of pamphylix. This is not an irritant contact dermatitis, or it's not a contact dermatitis, if you think about it. That's the other thing you'd think about. They have a lot of blisters. They got into something. The skin on your palms and the soles is the toughest skin on the body, so that it's going to take an incredible insult or a large amount of material to create an outbreak there. You're not going to have an outbreak on your palms and your soles when you don't have it anywhere else from a contact dermatitis, okay? You get into poison ivy, by the time your palms are breaking out, you've touched yourself and you've spread it all over. So if it's limited to the palms and the soles, it's probably this process and not something that you've gotten into. Atopic eczema, very important dermatitis. Atopic means out of place, strangeness, a funny disease. It was coined in 1923. It refers to the constellation of allergic rhinoconjunctivitis, asthma, and atopic dermatitis. Because of the perceived relationship now between asthma and atopic dermatitis in terms of filaggrin or profilaggrin abnormalities, there's a very close relationship now that's being studied quite intensively. Again, this is a eczematous eruption. It's a dermatitis. It's pruritic, dry, recurrent. It's predominantly in flexural areas. It's symmetric. And it's often associated with a personal or family history of asthma, hay fever, and eczema. This is something that begins in childhood. You don't take someone who's 30 years old and say, well, they've got this rash. Oh, they just developed atopic dermatitis. No, this is a pediatric disorder that extends through your life. I won't belabor this, but there are scoring criteria that have been postulated for that. I don't realistically use that, but you need to be aware that it's involved. It's a common disease. It affects 20% of all infants now in the United States. It accounts for 4% of all acute care pediatric visits. It's persistent or recurrent in 60–80% of patients, so it may affect, therefore, 5% of all adults in the country. Underlies 80% of all occupational hand dermatoses. And it's the 8th most common disease in those less than 25. You're going to see patients, if you go into primary care, that have this. These are the common areas, though it can be quite widespread. Again, flexural in adults, extensor more in kids. Typically involves the face and hand eczema. And this would be the typical kid. They're miserable. They're itchy. They're excoriated. They're scaly. They typically have infraorbital folds, Morgan-Denny lines. He's got a runny nose, secondary to the allergic rhinitis. This is a great picture because even as you're holding the baby, you can barely move around. It's scratching itself because it's so incredibly itchy. Typically, you get these lichenified areas from the chronic rubbing. It gets thickened. It's scaly. The skin lines get exaggerated, often hyperpigmented. These are just miserable individuals. Another baby with it. Typical flexural involvement. Now, one of the things I alluded to, I didn't put a slide because I don't want to snow you with this. It's been postulated in severe atopic dermatitis that there's an abnormality in profilaggrin or filaggrin. Filaggrin is the protein that disperses the keratin filaments in the membrane coating granules, so it helps construct your keratinized epithelial envelope. Recently in the literature, there's been a strong correlation between this abnormality and asthma. I don't think anyone fully understands what's the direct relationship, because there isn't filaggrin in the trachea, the bronchioles, or the lungs. But the point of fact is that you have a poor barrier function that in some way is triggering the asthma. So the theory now is less that it's internal and you're getting this external rash. There's a problem with your general barrier function. So things are getting into your body that are somehow triggering the asthma. Mueller dermatitis. Again, very common process. This is a very itchy pattern of well-demarcated, scaly, coin-shaped lesions. Mueller refers to coins, numismatic, a coin collector. Very common process, begins sometimes as minute clustered focal oozy blisters. People misdiagnose this as dermatophyte infection. You have maybe dozens, tens or dozens of these all over the body. For the most part, Tinea Corporis is one large continuous plaque. When I've seen it and it's very extensive and you look at it, it's really the extension of one enormous plaque. You don't get multiple small areas of Tinea Corporis. That really mitigates strongly against the diagnosis. Usually it's on the extremities, tends to be fairly stubborn. And again, as I said, it's commonly misrepresented or misdiagnosed. It rarely presents with separate lesions. So this is what you see, and you can see why why physicians think that it's Tinea Corporis, but they're scaly. You sometimes have almost an active-looking border there. They're crusty. Here you have lesions over here, so multiple lesions. And again, a typical area where you get a lot of serous sanguinous or serous material with, this is not scaling but crusting from minute blisters that are rupturing and leaving serum proteins on the skin. And it itches like crap. Asteatotic dermatitis. Coming winter, you guys will see this in the wards. I think it's very distinctive. You look at it and you say, whoa, that must be something. I'm not sure what it is, but it's got to be something. It's a itchy eruption on distal lower extremities, a disease in the elderly. It's been called winter itch. It has a very distinctive jigsaw pattern to the scaling with some hemorrhage there. To me, I liken it to a stream bed or a river bed that's dried out and cracked. And this is why I say that. So have you guys seen this before? Surely if you've been on the wards, you've seen that. Multiple cracking. You may have a little bit of edema on there. Very itchy. Another example of it, very distinctive pattern. I like the name, the French name, eczema craquelé, because that really describes the appearance of the lesions. Let me go back one. All right, and that's the last example with the typical cracking on there. Exfoliative dermatitis is a medical urgency. It's not a emergency. This is also called erythroderma red man syndrome. Patients are miserable with this, but they're not at risk of imminent death. It's a diffuse total body surface eruption of fine scaling, redness, continuous pruritus, doughy edema. It often manifests dermatopathic lymphadenopathy. That means you get generalized lymph nodes in the draining basins as a result of all the inflammation that's going on. And sometimes that makes people worried that they're dealing with lymphoma or another process, and it even comes to biopsy. About half the patients will have some eosinophilia. They're chilled. They're vasodilated all the time, so they're frequently very cold. And in very elderly patients, there can be some catastrophic consequences. They can go into dehydration. They can go into negative protein water balance or high output congestive heart failure. About half these patients are idiopathic. We have no clue. They're just unfortunate. It strikes, as many things do. As I tell patients, things happen. They say, why do I have this? It just happens. 25% of the result of severe drug eruptions that may or may not resolve with the withdrawal of the offending medication, so it may put into place something that doesn't necessarily go away. About 25% are from progression of other disorders. I told you stasis dermatitis can do this. Psoriasis is very common. Contact derm, a few other diseases, pityriasis rubra-pilaris. We just saw a patient in clinic the other day that has this. Small percentage relatively represents Sézary syndrome, which is leukemic T-cell lymphoma or just an extension of T-cell lymphoma. but a biopsy is usually indicated. Biopsies are not going to distinguish between these processes, however. You really need to get a history for that. By the time you get an exfoliative dermatitis, everything kind of blends into an appearance that it's virtually impossible for the pathologist to really distinguish between these various disorders. This is an example of red man syndrome. Diffuse erythema, diffuse flaking and dryness, very uncomfortable individual. This is a patient I saw recently from family medicine who had this for a long period of time. He was literally showering scale wherever he went. He was still in graduate studies. He was miserable. He was all swollen up. He was shaking, sitting there, just a really miserable individual. That was what he looked like anteriorly before treatment. Okay. Psoriasiform dermatitis, this is relatively new. Some articles present this as a distinctive dermatitis syndrome. It's a diffuse red, slightly scaly plaque. Even without therapy, there's no thick scaling. It's not characteristic of psoriasis. It doesn't localize to the same areas that you think about, the knees, scalp. And it's not as sharp, and it doesn't have well-defined borders. So this would be an example of that, where you can see here where, you know, it may look a little bit like psoriasis, but it doesn't have that thick, well-demarcated scale, even though there's no treatment. It's desquamating. It's patchy. It's more diffuse. It really doesn't have that appearance. Another example on the same patient. And yet another example. Hand-foot eczemas. This is a real problem for patients. I see it all the time in occupational medicine. We see it with people in the healthcare field. Nurses and doctors are washing their hands all the time. May turn into hamburger. It's an acute, subacute, or chronic dermatitis. It can be the result of other syndromes that are delimited to the hands. It can be from atopic dermatitis contact, nummular deshydrosis. It's itchy or tender, raised, cracked, hyperkeratotic. Nails may be affected if the growth areas are involved with this. And it may be very debilitating. It can separate people from their gainful employment. I see nurses and physicians that, you know, are unable to scrub up properly and can't participate in their activities because of that. It's usually chronic. I mentioned the other thing is professions necessitating wet work, and it may interfere with things. I'm going to show you some examples. A mild dermatitis. Chapping is a type of hand dermatitis. It may be an irritant hand dermatitis. You get cracking and fissuring and splitting of the fingers. It can be quite painful. Diffuse erythema, scaling, hyperkeratosis. A more debilitating form with marked hyperkeratosis. You can see where it would be very difficult to bend your hands and grasp things. Nails affected. And then most of what we see doesn't fill into these categories. So I've shown you these things get me fairly classic, but unfortunately a lot of things don't present classically as things don't in medicine. These are kind of non-specific dermatitis where you get red scaly plaques or papules. They can be limited or extensive that are not easily patterned in other things. They can do anything. They may occur acutely, may be chronic. They can get secondarily infected, as all these processes can, from scratching, and it may be modified by treatment. I'll just show you some examples. I don't expect you to be able to diagnose these offhand. I just want to give you an idea of the spectrum of things that you can see. You need to make sure there are no drugs involved with this, but, you know, scaly papules and plaques, patches, which can be quite severe at times. Papular. Now let's go a bit into treatment. I think a lot of these diseases can be treated by the primary care physician. They can be treated by you in your clinics and the wards. There are some common sense things that you want to do. Avoidance of irritants and any injurious materials and habits. You don't want your patients washing 20 or 40 times, if they can, their hands, or using overly strong materials. Emollients can help maintain the normal barrier, or at least prevent injurious things from gaining access to the skin where they're going to provoke more problems. Decrease hand washing. What I recommend to a lot of clinicians is use antibacterial hand washes. I don't wash my hands between patients. I would be hamburger. I see 40 to 50 patients a day. If I wash my hands 100 times a day or so, I would be hamburger in 2 days. You know, I wouldn't be able to work. We use a antibacterial spray that uses alcohol, but it also has an emollient in it. And I think it's great. I don't like the things that they provide in the hospitals because your hands feel kind of sticky and coated. But whatever, it's more effective than hand washing, which doesn't kill bacteria, it just washes it away. These have been associated with decreased infections in the ICU and what have you. And I think it's it's an easier and more practical way to go between patients. So I always spray off. I think that's an acceptable alternative. The options that we have are going to be topical steroids, calcineurin inhibitors, intramuscular corticosteroids, ultraviolet therapy, oral retinoids, and then we're going to have immunosuppressive therapies. The object here is to minimize the rash and discomfort. We're not going to cure people. One of the reasons I think I do a little bit better with this than some of the local dermatologists is I'm upfront about it. They get very frustrated because it keeps coming back, and I just tell them it's going to keep coming back. We can make you better. I'm not going to cure this. We don't know what's causing it. We're going to keep you functional. And they seem happy with that as long as you explain it. Comfort and functionality is more important than appearance with this. I have older patients, as I had one yesterday, where nothing is working very well. Excuse me. Guy's 85 years old. He's miserable. I'm going to give him Kenalog injections monthly for the rest of his life. You know, there's a risk of breaking bones and other problems. We can give him, if necessary, a bisphosphonate. But when you're that old, the main concern, I think, is quality of life and being comfortable and worrying less about the theoretic problems that are going to occur as a result of your medications. Topical agents, the tacrolimus, the Protopic, and Elidel work very well. But they're incredibly costly. It's like $300–400 a tube. They're good as an alternative. I just don't find them practical, and the insurance companies don't allow their use. I select what I regard as the most potent product appropriate for a site, and I give them sufficient amounts of medicine that they can deal with it. I find them patients coming in from primary care doctors with a 15-gram tube for a general body rash. You know, it lasts for 5 minutes and it's gone. And they come to see me because they get frustrated. It isn't that the medication was wrong. They weren't given the sufficient quantity of a sufficiently potent product to treat it. I would recommend you become familiar with several different medications. I also recommend avoiding clobetasol. I think clobetasol stinks, and I won't get into the reasons why that's so, but it's considered the Mount Everest of topical steroids by all the dermatologists and everyone else. And it really doesn't work that well, and I don't think it's as potent as people buy it. So I find a lot of patients that I see have been put on this, they're not doing well, and that's part of the problem. I change them to another steroid, and they do very well. Systemic therapy with oral steroids is frowned upon. Medrol dose packs suck, okay? They're not designed for any disease known to man. They start out with a sufficient amount of medication, they taper down, the patient, you get down below the therapeutic level, and it flares. Their duration isn't what you need. If you're going to treat someone with systemic steroids for any process, you give them the sufficient amount of medication to control the disease, and then you taper them based on the disease activity. You never taper them based on considerations of the accursed adrenal glands. Is that a reasonable statement? You heard it here. You taper diseases based on the disease. You get them off as soon as you can, but you don't want their disease to flare back. And the problems with oral prednisone is that you give them a reasonable dose, you stop it, and they explode back upwards. What I like doing, and what works for me, and there's not much literature on it, is IM injections of Kenalog. Those of you know who've worked with me know that I am entirely enamored with IM Kenalog and doxycycline and a few other things. But it works really well because it lets patients off gently and there's no rebound on that. So I recommend that as a treatment. Corticosteroids have a lot of local side effects. I'm not going to go through all these, but we worry about atrophy, stria, rosacea, impaired wound healing. I don't worry really about potential systemic absorption because, again, I'm not really worried about the HPA axis. I don't think, unless you have someone on this for really long periods of time, that enters into it. This is an example of atrophy for a patient that put a topical steroid in the antecubital fossa for a long period of time. The vasculature is readily visible. There are many systemic side effects from corticosteroids that we don't need to belabor. They're terrible medications. That's why you're told with severe dermatitis and collagen vascular diseases that you would much rather have someone on a cancer drug than steroids. Ironically, we would rather get them on methotrexate or low-dose azathioprine than keeping them on prednisone. Yet you guys glibly put patients on prednisone. I mean, if I told you you had to put your patient on azathioprine or methotrexate, you'd have a cow. But you glibly put patients on prednisone, and for long periods of time, it's a much more dangerous drug than those medications when they're properly observed in low doses. Physical modalities, we use ultraviolet light is great. We have a unit here, works better in pale-complected individuals. The insurance companies, in their wisdom, decided to start billing patients for each treatment. We were doing like a $20 copay for the entire course of therapy. Now they're demanding $20 or $40 with each treatment. Patients can't afford to do that, and we're really not able to utilize it. And there's no way around that. We tried to finagle it. We tried not to bill it. Not billing them is illegal. It's fraud. So logistics and the cost may be a factor. Logistics, they have to live near where you have the unit. There's little morbidity. You can get sunburn, photoaging. There's no evidence that narrowband UVB causes skin cancer. Systemic agents, we frequently use these. We treat it like psoriasis in severe, very symptomatic recalcitrant instances where you're having to use steroids all the time. You need to think about using immunosuppressive agents. Typically methotrexate, azathioprine, Cellcept, or mycophenolate mofetil. Neural is the fastest acting agent in low doses. It's good. These all require specialized monitoring and knowledge of the pharmacology to do well with that. Any questions? Yes, sir. The elastic stockings have a preventative effect. When you have stasis dermatitis, a patient is swollen and itchy, they're not going to tolerate that. They'll kill you. It's difficult to get on. They're swollen. I think you need to keep their legs elevated. However, there is a role for the stockings in preventing exacerbations. So that I think if you have additionally, you can't put the topical steroids on when they have the stockings on. They're difficult to get on and off, so it's not very pragmatic. But compression stockings tend to prevent the stasis dermatitis. Another thing that I suppose you need to consider is that you'll see a group of patients, particularly diabetes, that get recurrent cellulitis. They get it over and over and over again. In those instances, you need to think about dermatophyte infections, whether it's obvious or not, and stasis dermatitis and edema. Those are really the three things that will lead to that, and you need to address that to prevent the recurrent episodes of cellulitis. Any other questions? That's it.